So great pleasure to be here again this year for the second Kinshine Symposium. Everyone knows who Kinshine is, maybe? Ken, you want to just sort of raise your hand? Yeah. The idea started with just what the school wanted to celebrate careers of people who had been, really remarkable in changing health and healthcare in the systems. And not just, with one or two articles that push the science forward, there are a lot of people like that, but whose career really exemplified what it was that we were trying to achieve here at the school and what we're hoping our medical students might aspire to become. And so it was perfect to name that for Kinshine because he obviously had that kind of career. I won't go through all the details of all the different things that he's done in his career, but that I would say that that my job now was sort of a mid-career move for Ken. Being a dean of a med school, that was kind of a mid-career thing. And then he quickly moved on to bigger and greater things than that. And this is our second year for the Shine Symposium, and it was not hard to find the right person to bring here, and that's Steve Schroeder. So Steve's a very remarkable Californian, through and through. Spent a little time elsewhere, but mostly in California. He was born in El Cerrito, which is just across the bay from San Francisco. Went to Stanford as an undergrad, then went to Harvard for med school, and then to UCSF. And really started, yours was the first general internal medicine division anywhere, right? No? Thought it was. No. I'd love to be able to say it was the first. Well, it was the first one at UCSF. Yes. And it was a powerful one. I mean, they did some tremendous things very early on in changing the focus from very specific things. And your career did this too. So he worked for the CDC as well as an epidemiology officer for a while. And his first papers are about salmonella and salmonella toxicity and all that, sort of typical papers. But then he quickly changed to be focused really on healthcare, on improving the quality, and improving outcomes. That work continued. He became the head of RWJ in 1990. Okay, that one I got right. And did that for 12 years, and then returned to UCSF after that, where he continues to work very hard, now mostly focused on smoking, but not really, focused on everything, all the things that are important in health and healthcare. And I just wanted to share with you a couple of his articles that I find just remarkable. One was, I'll just give you two from 1973. Lowering broken appointment rates at a medical clinic. It was published in Medical Care back in 1973. So, we feel like we're just addressing that problem now. So 45 years ago, you were already, well ahead of us and trying to address that issue, one that we still struggle with. The next one, though, I love this. Use of laboratory tests and pharmaceuticals, variation among physicians, and effect of a cost audit. This was published in JAMA also in 1973. It's great to look back at that paper and to see how important it was. He just completely focused on value. Did a whole series of papers after this about the importance of improving quality and that it wasn't really associated with how much you spent and how we needed to disentangle those and really focus on the quality as the key essential element. All right, now I've got to be able to read my own writing. Extreme variation observed in costs of care emphasizes the need to relate costs to quality and efficiency. So again, 1973. That sounds like something that we would write today. So really remarkable career and remarkable person. And I know that many of you had an opportunity to spend some time with him today. But at least now we all get to spend some time listening to him, and we'll have plenty of time for Q&A at the end. So Steve, thank you very much for coming and educating us.
Thanks, Clay. That was very generous, and it's great to be here. I normally don't read speeches, but I'm going to do this one because I've never done a life story speech before. And you'd think I know it by heart, but in fact, I've tried to integrate things. So let me start. It's a privilege for this Californian to be here in Texas, helping to celebrate the remarkable career of Ken Shine and to visit the early stages of what promises to be a path-breaking new medical school. And I was delighted to meet some of the faculty and some of the wonderful students today. And I have high hopes for you, and I follow you with great interest. Ken Shine is one of the giants in American medicine. I had regular contact with him during his distinguished presidency of what was then called the Institute of Medicine, now the National Academy of Medicine. It was easy to spot his enormous strengths: energy, intelligence, extroversion, and a huge span of interest. I feel certain that is the same Ken you got to know here. I don't think he slowed down at all. I don't know how he does it. Maybe there's a portrait in your attic that shows you withered and all that, like Dorian Gray. But, I want to mention two other attributes, though. First, Ken was not afraid to embrace controversial issues when they meshed with his personal values. He was a courageous advocate for doing the right thing, even when it might carry a political cost. The other attribute was told to me by several women on the IOM Council. Ken was a quiet and steady mentor of women faculty members at a time when such behavior was uncommon. So I was asked to share with you today, by Clay, my own journey. Like Ken, I tried to make a difference. The road I traveled had many twists and turns, and I was privileged to have had a rich set of experiences at several institutions. In some instances, my attempts at change were futile. In others, they turned out better than I had hoped. I'll start with a brief personal background. My parents instilled in me that there were many injustices in this world, and that I had a responsibility to try to make things better. What drove me to medical school was the hope that psychiatry was a way to improve both personal health and the health of the public. But in medical school, two things happened that led me down a different path. The first was, I'm embarrassed to say this, that I flunked a biochemistry midterm exam, for which I was unprepared. This was during my first semester. Not surprisingly, that converted me into a more diligent student. In doing so, I became more invested in the substance of medical science. The second event, which was more pivotal, was my experience in 2-course psychiatry clerkships, which were taught, unfortunately, in a very dogmatically Freudian fashion that didn't seem relevant to population health. I know population health is a major theme of this school. So I seized on a plan B, and I enrolled in a program that sent me for 3 months to Salvador Bahia in Brazil to study schistosomiasis with a distinguished professor there. Although I greatly enjoyed the experience, I concluded that in order to sustain an overseas medical career, you need to understand the culture, and also it would be helpful to have technical laboratory expertise and to secure funding for those purposes. And I didn't think it was necessarily a good personal fit. 2 incidents from that long-ago experience have lingered. One was visiting a small interior village near a schistosomal infected stream. Public health officials, and I should advance the slide. Public health officials had created a clean source water pump that village women used for cooking, while their children frolicked in the nearby contaminated stream and other women washed clothes there, thus exposing their skin to penetration by a schistosomal parasite. So here was the pump, and this is what they use for the water for cooking, but then they expose themselves here. This is from 1964. The message is it is not enough to install public health measures. They must be accompanied by health education. The second incident occurred when my sponsoring professor was hand-washing laboratory glass beakers. "Schroeder," he remarked, "in your country, you're careless with things and just throw them away. We can't afford to do that here." I will return to the concept of medical waste. So having examined and discarded Plan B, which is psychiatry, Plan A, rather, which is psychiatry, and Plan B, international health, I came up with Plan C. You can predict where this is going to go. There was much to improve on our own country. I would train as an internist, learn about public health, get a management position in a healthcare system in order to spot possible ways to improve things, and then get a federal government job so that I could help implement solutions. In the end, I never did get that government job. So Plan C didn't work out either. And I met with the students today, and a lot of them didn't know what they're going to do next. And I said, don't worry, you may never know what you're going to do next. Having given a sense of my early wanderings, I'll fast forward through my subsequent career, which Clay did to some extent anyhow. They included medical residency, 2 years at the CDC in Atlanta, 5 years as medical director of the George Washington University Health Plan and Medical Clinic, 14 years at UCSF, starting with health policy research, and then forming the Division of General Internal Medicine, 12 and a half years as president of the Robert Wood Johnson Foundation, and the past 15 years back at UCSF directing the Smoking Cessation Leadership Center. Along the way, I became involved with many different issues and had mixed luck in addressing them. Here are 5 in which I tried to make a difference. Limiting salmonella infections, medical cost containment, and Clay read some of those papers, covering the uninsured, care at the end of life, and smoking. And that's only a partial list. I tilted my lance at a lot of things. My residency in internal medicine, so let's turn to salmonella first. My residency in internal medicine was punctuated by 2 years spent at the CDC. This is a time when physicians were subject to the draft for the Vietnam War, where I worked on the epidemiology of salmonella. Our mission was to protect citizens from infection. It quickly became obvious that a major cause of salmonella infections was ingestion of contaminated poultry. At that time, the U.S. Department of Agriculture relied on technical advice from a research laboratory affiliated with the Big Ten Midwestern School. When I visited the lab, I asked its director, why was there so little regulatory control over the hygienic conditions of poultry raising and processing? His answer was, well, the situation is complicated. I don't want to overburden the chicken farmers and the food producers. Several years later, I learned that a major source of support for his work came from, guess what? The food industry. And I realized that I had neglected a basic premise of health policy. When actions are not taken that seemingly should be, there are usually important forces behind that inertia. Or as one colleague put it, when you see a turtle on a fence post, it didn't get there by itself. So at that point in my career, I stopped at diagnosis. I didn't get into therapy. It didn't occur to me that I could have forced the issue more vigorously. You'll note, up to date, that tensions regarding the proper regulatory oversight of industry remain controversial, with pendulum swings usually dominated by who's in the White House. So let's turn now to medical cost containment. The United States leads the world in healthcare in only one category, how much we spend. And there we are. This was true early in my career, when economists were warning that the amount of gross domestic product spent on healthcare was soon going to pass 10% of the GDP. Oh my gosh, 10%. A level they felt was unsustainable. Well, it obviously was sustainable. Today, the same warnings abound as we approach 20% and far surpass what other countries spend. In my first real job at George Washington Medical Center in DC, as Clay mentioned, I ran into 3 examples of what my Brazilian professor would have called waste. As a capitated health plan, we wanted to both to keep people healthy and to prevent hospitalizations. I kept track of all our hospitalized patients. I had actually a whiteboard in my office. We were sufficiently small I could do that. And noted a peculiar pattern. Most psychiatric hospitals lasted exactly 30 days. It turned out that in the District of Columbia, hospital insurance coverage for mental health episodes was, guess what? Only good for 30 days. I asked our psychiatry chair about that pattern. He told me that it was based on clinical experience, but he couldn't provide any supporting evidence to back that up. So we reconfigured our mental health services model, vastly reduced hospital days for mental illness, and despite dire warnings from our psychiatry chair, suffered no known suicides or other adverse outcomes. Another case of possible overuse arose during my daily review of lab test results for our clinic patients. We had a large number of part-time physicians who were working at the NIH and then came for a half day to our clinic. And it became clear that there were wide variations in physician laboratory test use. There was actually a 17-fold difference from the most parsimonious to the most costly, even when you controlled for types of clinical conditions being seen. We did a modest experiment sharing the continuum of lab use patterns with the physicians and showing how each individual compared with his peers. And it was almost all his at that time. We then measured test use after this exposure and found there was a 29% decline in laboratory test use, just after being shown where you stood in comparison with others. And the greatest decline came from the top third users. Variations, and that's the paper that Clay mentioned. Variations in the use of medical care have since become identified from many settings, and audit with feedback, which is what we did, has become a standard way to try to modify physician behavior. The third example of why our country spends so much relates to the profound pro-technology fee-for-service valuation of payments to doctors. Although our specialists at George Washington were paid on a capitated basis for our HMO, they also submitted routine bills for ledger purposes. I was flabbergasted to see how high the charges were for some very simple procedures. My subsequent response to these observations was a traditional academic one. I wrote a paper. The next slide shows a model of even how general internists can triple their incomes by practicing a more technology-expensive style. So we constructed 4 hypothetical models of a general internist practice. Model A saw a full panel, 5% fewer patients, 5% fewer patients from Model B, 5% fewer patients from Model C. But what we did as we lowered the patient numbers, we ratcheted up the intensity of lab tests and increased the net income from $31,000 to $89,000 according to the fee schedules. Again, you normally think of these biases as occurring only with radiologists or surgeons, but even with a humble general internist such as I am, you saw that. The next few slides are examples of other work I published on this field. First at George Washington and then at UCSF, that tried to quantify, explain, and even change these patterns. So this was a test where we looked at interns in the hospital, asked our faculty to rate them according to quality, and then quantified their lab use profile, and found that there was no correlation between how much they spent and how well they were perceived as clinicians. The next one was, how did that turtle get on the fence post? So we went through documents to look at Blue Shield and see how the current system of fee-for-service valuation, and this was back in 1979, how did it get that way? And this was mainly an analytic study going back through the codification. And clearly, the medical specialists had a lot to do with setting those fees. Subsequently, we tried to answer the question, how much did increasing use of medical technologies contribute to rising healthcare costs? And we did this at UCSF, and we found that, in fact, medical technologies did increase over the 5-year period we measured, and that when new technologies came on board, rather than being substitutive for existing ones, they were additive. And then we did something that I think is very salient to what you're trying to do here at Dell. We tried to see whether we could make a dent in medical costs. And we got funding from the Hartford Foundation and set up a randomized trial where we had a control group and 2 intervention arms. One intervention arm was to educate the house staff, this is on the medical wards, about the appropriateness of use of various technologies. And the third arm, control education, was audit with feedback, just like we had done at George Washington. And everybody thought we'd made a difference until we cracked the code. Zippo difference at all, no difference. And our conclusion was that the overwhelming incentives embodied in the hospital, and these were really excellent clinicians, these were award-winning teachers, the residents loved them, we gave them pizza for lunch, and the take-home message was, nice try, Schroeder, didn't work. Was I successful in these cost containment efforts? In a narrow sense, I was, because medical journals were interested, and publications raised consciousness and bolstered my academic standing. This time I not only made a diagnosis, which was excess medical care and costs could be safely curtailed, but also identified some possible solutions. This work led to my selection for the inaugural Physician Payment Review Committee, now known as MedPAC, where we ruled on coverage issues for Medicare, as well as the California Blue Shield Technical Advisory Committee. When I came to Robert Wood Johnson Foundation in 1990, knowing my background, our board, who were mainly business people who were concerned about these issues, asked me if we should take on medical cost containment as a central grant-making goal. Given my background, my response kind of surprised them. I argued that, as important as the issue was, the forces promoting cost escalation were so strong that I did not see how the Robert Wood Johnson Foundation could change things. Much more recently, I was asked to chair a commission on physician payment reform that issued a series of policy recommendations, at least one of which has since been adopted. And Senator Bill Frist, who was the honorary chairman of this, I was the PI, and I published a sounding board in the New England Journal that summarized these articles. So a lot of work, a lot of publications, good journals. Did any of it make any difference? My verdict would be not much. My publications, along with those of others, helped to illuminate why medical care costs so much in this country. And the work also led me to experience firsthand the world of medical policy, which was helpful for my subsequent efforts when I went to Robert Wood Johnson. But the magnitude of the supply and demand forces pushing for more care and more expensive technologies simply overwhelmed our modest efforts. As a result, much public and private spending is diverted from other worthy public goods such as education, infrastructure, transportation, or the environment into low-yield medical care. So in the instance of medical cost containment, just identifying the diagnosis and potential treatments were not sufficient. What was lacking was political and advocacy muscle to make the treatment work. An interesting epilogue is that our son, Alan, who is a pediatrician at Stanford, has spearheaded a movement called Safely Doing Less, and Chris works with Alan on similar kinds of projects, in which he tries to identify and drive down the use of pediatric care that does more harm than good, in addition to wasting resources. His timing might be better than mine, because there seems to be much more of a push today. And one example of that is the recent pronouncement by Amazon, Berkshire Hathaway, and JP Morgan Chase that they'll join in a private sector attempt to address what Warren Buffett calls, and you got to remember this quote, you might want to write it down, a hungry tapeworm on the American economy. A hungry tapeworm on the American economy. And Harvard Business School says the same thing. So this is their U.S. healthcare value shortfall. Here is a quality metric, life expectancy, and here's healthcare spending per capita. And we're an outliner, and we're number one, not necessarily where we'd like to be. I applaud Dell for its efforts to work in this area. I think your timing may be better than mine. I hope your outcomes are better. Let's move now to covering the uninsured. The United States continues to stand all by itself as the only developed country that doesn't provide basic health insurance for everyone. It's interesting that this was the recession and this was the passage of the ACA. Since the passage of Medicare and Medicaid in 1965, there have been many attempts at both fundamental and incremental expansion, almost always pushed by Democrats and opposed by members of the Republican Party. Although I have no personal expertise in the economics of health insurance, I feel deeply that every person deserves a right to basic health care. I formally engaged the issue first when former Senator Russell Long, a Democrat from Louisiana, was advocating for catastrophic health insurance that would seemingly do a good thing. It would set a limit for patients' financial liability. He argued that high-cost hospitalizations were rare, and thus the government expense would be minimal. Based on my clinical experience, I thought he was greatly underestimating the prevalence of high-cost hospitalization, and also that his legislation would amount to indirect subsidy of intensive care units. This in turn would make overall coverage expansion more expensive and less feasible. So we secured funding to test our theory in 17 hospitals in the San Francisco Bay Area and documented that the center's logic was indeed flawed. High-cost hospitalizations were common, accounting for from 1/5 to 2/3 of a hospital's total billing, with, not surprisingly, the highest proportion occurring at large referral hospitals. Our study was published in the New England Journal of Medicine, and our conclusion was national catastrophic health insurance is likely to pay for much chronic illness and terminal care and divert resources toward acute care hospitals. In other words, catastrophic health insurance would have selectively fertilized intensive hospital care while ignoring basic medical care. We took a step further. We published these results in a letter to the Washington Post. We subsequently heard that Senator Long withdrew his bill, in part because of our article. So in that instance, we worked to avoid feeding the medical cost tapeworm, although we missed a chance to shield some patients from high-cost medical bills. My next brush with expanding health insurance, and the most controversial one, came in 1993 at the Robert Wood Johnson Foundation, shortly after the election of Bill Clinton. He had campaigned on a promise to expand health insurance. Since its formation in 1972, the foundation had worked to expand health insurance also. So our very conservative board told me, Schroeder, we didn't vote for Clinton, but you should provide technical assistance to help him plan his proposal. Accordingly, we organized 4 well-publicized meetings, which we called Conversations on Health, in different regions of the country, in which Hillary Clinton, who was, remember, in charge of planning healthcare reform, heard testimony from various groups about what they wanted from health reform. And there's Hillary, and there's a young Steve Schroeder. I presided over these meetings. This was in 1993. Although our foundation had no role in designing the Clinton plan, this was in the centerfold of Time magazine, by the way, we were severely criticized by Republican congressional leaders for acting in a partisan manner and implicitly for elevating the profile of Hillary Clinton. Not the most popular politician in the state, I would add. In the end, the plan never even made it to the floor of Congress, and analysts felt that its failure cost the Democrats their role in the Congress. A few years later, I published an article in the New England Journal that attempted to explain why the U.S. is such an outlier in not providing basic health coverage for all. I cited a number of reasons, but chief among them was concern about whether government should solve social problems, as well as the partisan kind of divide that surrounded this topic. But to the surprise of many, a bipartisan bill, the State Health Insurance Program, State Children's Health Insurance Program, or CHIP, was enacted in 1997. Senator Kennedy and Senator Hatch from each of the 2 parties collaborated on this, a rare instance of crossing the aisle. And it was enacted in 1997 to expand insurance coverage for poor children. After the bill was passed, we at the Robert Wood Johnson Foundation provided extensive resources towards executing CHIP, including publicizing its availability in low-income communities and ultimately helping to simplify the enrollment processes in many states. Ultimately, the rate of uninsured children fell to modern lows, and we were part of making that happen. I felt proud of that. What lessons did I take away from working on health insurance coverage? First, of all the topics I worked on, it is the most deeply entrenched in partisan politics. Rational arguments have little power when confronting strongly held suspicion, for example, about the integrity of government, and we're seeing that play out today. Although I even considered advising the foundation to stop working for health insurance coverage, I ultimately decided that we should stay the course, even if in the short run those efforts would be futile. My decision was based on the moral imperative that everyone deserves access to basic health care. And there's a story that I like to tell. You have to judge whether it happened or not. Wilbur Cohen was the secretary of HHS when Medicare was passed. And he was one of these virtuous civil servants, and he lived such an exemplary life that when he died, he went to heaven. And he was granted an audience with God in the celestial office room, Thursday afternoon at 2 o'clock. And God said, Wilbur, you lived an admirable life. I'm going to grant you the opportunity to ask me any question you'd like. And Wilbur said, God, will the United States ever have national health insurance? And God said, yes, Wilbur, but not in my lifetime. So in this instance, the diagnosis was easy to make, and the potential solutions were different forms of health insurance expansion. But the implementation barriers are dominantly political, and they show no signs of weakening. The contrast between the bipartisan passage of Medicare in 1965, which got a lot of Northern Republican support and lost a lot of Southern Democratic support, there were a lot of Southern Democrats in 1965, and the debates about the Affordable Care Act is striking and shows how polarized we have become as a society. So I'm going to move now to care at the end of life. During my many years as a clinician, I frequently saw cases where aggressive care continued in the face of a hopeless prognosis. And as my own parents aged, they asked me how they could avoid the fate of some of their friends who felt railroaded into cancer chemotherapy against their better instincts, often at great suffering and expense. I reassured them that their physician's son could prevent that. And during a sabbatical in London, during which I studied European healthcare systems, I learned how much we are an outlier when it comes to end-of-life care. And typically I published this one too. I was privileged to go and visit academic teaching hospitals all over Europe. And being a professor in Europe is pretty rare. So when I said, I'm a professor, I'd like to come visit you, they would have 2 or 3 professors of medicine at UCSF, we had probably hundreds. So I was given the red carpet treatment, and I went on rounds on the wards, and it looked just like they would anywhere at UCSF, at UNC. And then I said, take me to your ICU. He took me to the ICU. The ICU was really different. It was different in 2 ways. One, for a 1,000-bed hospital, they maybe had 10 ICU beds, and the train wrecks weren't there. You know the train wrecks, people who were unconscious, being breathed, being ventilated, the pressure being sustained, being dialyzed. They just weren't there. And so I said, where are they? And there was uncomfortable silence. People looked at their shoes, and finally, one younger person would say, Dr. Schroeder, I spent a year or 2 at Yale or at Hopkins or at Vanderbilt or at Duke or at UT or at MD Anderson, and I love the training there. Your teaching is so good, but you don't know when to stop. You don't know when to stop. And I attempted to diagram this here. U.S. healthcare is in red, European healthcare in blue. At every step along the way, the wishes of the patient or the family, the impulses of the generalist, the impulses of the specialist, the referral to a community hospital, to a tertiary hospital, to the ICU. We have dominant forces pushing much more towards intensivity than our colleagues in Western Europe. And this amounts to a major culture difference. With that as background, when I came to Robert Wood Johnson, I was very interested in a large research study supported by my predecessor, Lee Clough. It was called the Support Trial. How many of you have ever heard of the Support Trial? Not many. It's probably one of the most important papers in healthcare in the 1990s. It enrolled over 9,000 patients suffering from life-threatening illnesses in 5 prestigious American teaching hospitals. Phase 1, which is the baseline, documented what the investigators had feared. Too many patients, here it is, too many patients died in pain without their wishes being carried out and hooked up to myriad different kinds of machines. Confronted with these stark findings, the investigators resolved to improve them. It was felt, in error it turns out, that prognostic uncertainty and inadequate understanding of patients' wishes were the key barriers to improving care at the end of life. So, half of the over 5,000 patients in phase 2 received interventions to overcome those barriers. Half served as control subjects receiving usual care. And like with the cost containment experiment we did at UCSF, people in charge of implementing these felt sure they'd made a difference. Again, they were wrong. At the end of the 2-year study period, when the code was broken, the investigators were astonished to find no difference in the targeted outcomes between the 2 groups. Physicians were equally unaware of patients' wishes, reports of severe pain were equally high, and costs of care were equivalent. I remember vividly when the project officer at our foundation came into my office and burst into tears, explaining that we had just wasted $29 million on a negative study. And I reassured her that in a way this was a blessing, because it illustrated that we had identified a very large and important problem, and one that would not respond to a quick fix. When a support study was published in JAMA in 1995, it made front-page news in major newspapers across the country. For our part, we felt that we now had an obligation to improve care at the end of life, so we embarked on a campaign which we called Last Acts. That contained 4 major goals: improve professional education about end-of-life care, first goal. Second goal, expand access to palliative care. Third goal, lower institutional and regulatory barriers to needed care, especially pain relief. So the second and third are really important. And 4, change public education about these issues. By far the most successful element was jump-starting palliative care, by creating the Center to Advance Palliative Care at Mount Sinai in New York, first under Chris Castle and then under Diane Meyer. As shown in the next slide, which Diane sent me, palliative care is now well established in virtually every large and medium-sized medical hospital, where it brings the potential to ease the burden of serious illness. It's a wonderful program. Another campaign element had both intended and unintended consequences, and this is sort of under the no good deed goes unpunished. We worked with a variety of professional, regulatory, and religious agencies to promote adequate pain relief. Part of that movement even included creating pain control as a new vital sign. Anecdotally, the campaign did succeed in lowering barriers to adequate analgesia, especially for cancer patients. But a consequence of that relaxation may have contributed to the current opioid epidemic, in that physicians may have been lulled into being less vigilant about prescribing and monitoring medications to relieve pain. So in retrospect, how would I rate our involvement in end-of-life care? I would give us high marks for highlighting the problem, identifying possible solutions, and especially for championing palliative care. The possibility that our work on pain control had negative and unforeseen outcomes is sobering, and it's not clear yet whether the overall situation has improved. What does seem certain is that the issue remains immensely salient, as witnessed by Atul Gawande's recent bestseller on Being Mortal, and the advocacy in many states for right-to-die legislation. Now I'm going to turn to smoking, which is probably what most of you thought I was going to spend most of my time on. In spite of impressive progress over the past half century, tobacco use continues to exert a major toll on death and disability. I grew up in a household typical of my generation. Actually, let me ask a question. How many of you, your parents smoked? How many of you smoked in college? How many of you have adult kids who smoke? Yeah, isn't that amazing? That's what's happened over time. In the course of my youthful experimentation with cigarettes, I found it easy to resist the habit, and after many years was able to convince my parents to quit. As a clinician, I was often confronted with patients whose illnesses came from smoking, and I recall bitterly how frustrating it felt to see fine men and women die way too early. It was also clear that the tobacco industry was both ruthless and predatory. So when I interviewed for the Robert Wood Johnson presidency, I proposed that a good goal for it would be to reduce harm from substance abuse, including tobacco, alcohol, and illegal drugs. We ultimately did accept that goal, despite some resistance from staff and board. What they were concerned about was retribution from the tobacco industry, and we did get some of that, and the fact that they favored other issues to work on. Over time, we invested over $500 million in tobacco-linked projects. We didn't start with a planned blueprint because we didn't know what was going to work, but we rather invested in a host of strategies, keeping those that seemed to make a difference and discarding those that did not. We stimulated clean indoor air laws, raised public support for cigarette tax increases, created advocacy organizations, sponsored research, and supported tobacco control advocates. Surprisingly, no other national foundation had worked on smoking, so we had to learn as we went. In the end, tobacco control became a signature accomplishment of our foundation, and the 2007 book, The Foundation, by Joel Fleischman, listed our work on tobacco as one of the 12 highest impact foundation programs of the 20th century. As part of an honor roll that had the Green Revolution, the Flexner Report, Sesame Street, and others. Since returning to UCSF, I have continued to work in this area, attempting to persuade organizations to undertake more muscular smoking cessation efforts at a time when smoking is increasingly concentrated among the most vulnerable, such as those with mental illness or substance use disorders. These efforts have also been quite successful. So what did we accomplish with our work on smoking? Pretty good. Clearly the trends are favorable. So this has two important lines. One, overall prevalence of smoking. Surgeon General report came out in '64. We were almost 45%. We're down now to about 15%. And it was previously thought, well, when smokers quit, it would be the light smokers. The residue would be the hardcore smokers, in which case the cigarettes per day of smokers should have gone up. But in fact, it stayed constant at about a pack a day till about 85, and now it's down to about 13 cigarettes a day. So a double progress. What about with children? Again, we're at a modern low. Some of you may ask me in the Q&A about e-cigarettes. That's usually the first question I get at a cocktail party. While it's not possible to disaggregate the impact of our work from the many others who worked on tobacco control, I'm pretty confident that we made a contribution. So, what does it take to achieve progress in areas such as smoking? My colleague Steve Isaacs and I analyzed 4 success stories in public health where the public good prevailed: lead poisoning, traffic fatalities, combating dental caries with fluoride, and tobacco. And 4 elements were critical to each of these triumphs. One was credible scientific evidence about the problem and about possible solutions. The second is fearless advocates, such as Ralph Nader on traffic safety, Candy Leitner from Mothers Against Drunk Driving, and Herb Needleman for lead poisoning. The third element was media campaigns, such as for designated drivers or the Truth Campaign for anti-tobacco industry messaging. And finally, laws and regulations to safeguard against pollution of air or water. Here's the regulatory issue again. To mandate safety belt use and to protect against drunk driving. It's interesting that some major figures in the current administration are either dismantling regulations, such as Scott Pruitt in the EPA, while others are in favor of it, like Scott Gottlieb at the FDA about taking the possible nicotine out of tobacco or lowering it. These 4 elements all relate to the tobacco story. In particular, the knowledge of the dangers from secondhand smoke galvanized support for tobacco control among the non-smoking group, which is now up to 85%. I'm often asked, can these same principles be used against the obesity epidemic? And my answer is, the only time I've ever been bothered about secondhand fat is when I'm in the middle seat of an airplane and 2 large people get on either side of me, but that doesn't happen very often. So it's hard to mobilize the non-obese, and there are fewer of the non-obese, by the way, than there used to be, to get so involved in that. 2 other factors that might be very special to the tobacco situation are the lethality of the program, which I showed you of the problem, which I showed you in a previous slide, and the toxicity of the industry. So that's my journey. Let's look back on it. And as I look back on these adventures, I realize that I'm either a true generalist or I suffer from ADD, because these topics are all over the map. And I didn't even mention a lot of personal energy spent on trying to bolster the primary care workforce or to increase underrepresented minority groups in medicine, or a small but aborted attempt to study the epidemiology of gun violence. But there is a common thread linking these seemingly unrelated 5 issues: salmonella infections, medical overuse, lack of health insurance, end-of-life care, and smoking. With the exception of salmonella epidemiology, they were all problems much in evidence in my work as a clinician, and whose remedy depended on finding appropriate policy and advocacy solutions. It was also clear that it was easier to identify the problems than to fix them. That turtle on the fence post didn't get there by itself, and there are almost always powerful forces that are aligned to preserve the status quo. In work of this sort, one has to decide when is the right time to try to change things. In my experience, that's easier to identify retrospectively than prospectively. People are drawn to careers in medicine and other healthcare settings in order to make a difference. Many of you will devote your efforts to clinical situation, and that remains a glorious calling. Others may try your hand at broader systemic issues. Whichever road you choose, let me offer a few lessons learned from personal experience and observing others. Oh, and I should have shown this before. These are the ingredients for success. So these are the elements. As a philanthropist in Iowa once urged, leave it better than you found it. Leave it better than you found it. Find ways to improve unsatisfactory situations, whether big or small. My father was a role model for that. When he'd be at the beach, he'd pick up stray bags and put them in his pocket and put them in a garbage can later. He left it better than you found it. Understand the landscape you're trying to alter before you act. In the first opening scene of The Music Man, they're all riding in that train, remember that? And this one guy keeps popping up. You got to know the territory. These are all these salesmen. You got to know the territory. So before you design a plan, make sure that you understand what you're trying to fix. Be flexible concerning strategies. I've seen too many zealous reformers say, I know how we're going to fix it, set in motion a plan, and then never deviate, even when it looks like the plan isn't working all that well. 4, set an example by your own actions. As I was telling the students today, I'm sorry to say that too many people talk a good talk but don't walk the walk and can be accused of being a hypocrite. And I'm thinking of people who are in favor of global climate change issues and then hire personal jets, that sort of stuff. Keep your word. Integrity is a precious commodity. Once lost, it's hard to get it back. And I told the students this also. Don't fall into the false dichotomy of choosing between work or family. Some of the most fulfilled people I know have worked hard while still nurturing a strong family life. Have good taste in those you work with. Life is too short to work with jerks. And for those who want to try systems reform, you should write about what you'd like to fix and how that might happen. It clarifies your thinking and helps to spread the message. Last but not least, trust your judgment. If you think something is worth doing, don't let others dissuade you. Whatever path you choose, I wish you great success. I hope that you'll learn as you go, and that you'll be able to work on issues that you care about. Remember the inspiring quote from Martin Luther King, "The arc of the moral universe is long, but it bends towards justice." And again, a salute to Ken Shine, who's inspired us all. Thank you.
Thank you very much. Great. Well, that was wonderful. Thank you very much. And I love the way you ended it too, to inspire us all to mimic in any way the kind of career that you had. So thank you for being here. So we have some time for questions. I know you're going to have one, Ken. I've never been in an auditorium with Ken where he didn't have a question. Have you all? I mean, that'll be a strange day.
Thank you very much. Steve, thank you for being our lecturer. Thank you for an outstanding talk. I'm often testifying before the Congress. I often try to capture the notion of the silent voices of scientific success, the people who didn't die because of better cardiac care, the people who didn't die as a consequence of not smoking or never taking up smoking. And I think you clearly deserve enormous personal credit for many millions of lives saved, and particularly for the work on adolescents in terms of stopping adolescents from smoking and helping to do that. So I think we have to salute you for that personal contribution. I would also point out that we recruited a spectacular dean, but we also recruited his wife. His wife is an outstanding palliative care nurse. So in fact...
No, doctor.
Huh?
She's a
I'm
doctor.
sorry, physician.
Yeah.
She's actually a hospitalist who spends about half of her time on palliative care.
She's blushing back over there. She's there. Yeah, close to there.
Raise your hand, wife.
And finally, I want to ask you a question. Earlier this year, the National Academy issued a report on trying to deal with drug costs. And you're going back to your original interest in controlling costs. Drug costs are on the agenda now, producing major problems, people looking for solutions. There were a number of recommendations by that group that included banning advertising of drugs for a variety of reasons. Secondly, allowing the federal government to regulate prices of drugs through the Department of Health and Human Services, and preventing pharmaceutical companies from delaying transmission into generics. I'm curious as to, given your experience with trying to control costs and dealing with the establishment, which includes pharmaceutical companies in a big way, what you think about the approach that they're proposing And what do you think, there's any possibility that in the current climate any of that could happen?
So those are, thanks for the compliments. Those are three issues. They're only very political. We're one of, I think, only 2 countries that permits direct-to-consumer advertising of prescription drugs. And in my demographic, I don't watch much television except the news. And boy, we're a broken down group of news viewers because every commercial is for something medical. And they're all costly. So, and the medical profession didn't want that to happen, but our sense of free speech has let it happen. So I don't know whether the Supreme Court would let us ban that, but I would be in favor of not doing direct-to-consumer advertising. Pricing, we have a government that's very concerned about spending on social services, is worried about budget busting, and yet won't let Medicare, which is the largest purchaser of drugs, do bargaining for drug costs the way other countries do. And that's just a political issue. That's just all political clout. So I'd be in favor, if we wanted to stretch our tax dollars, the counter by the drug companies are that we need those dollars for R&D. I'm not sure they've made a good enough case, but that's their counter. At Robert Wood Johnson, because of our historic designation of coming from the Johnson & Johnson company, I didn't get into drug prices because it would have looked like too close to the bone. The generic issue, same thing. This is just a way to keep the prices going up. So drug prices are not the largest component of our dollars spent on medical care, but the fastest growing one. So we have right to be concerned about it.
So I have a question about where we're going. So if you looked at the introductions in the papers that you showed us, even back into the 1970s, you talked about the cost of healthcare increasing and being unsustainable. And way back in the 1970s, in some of those papers, you talk about, well, the pressures now are going to force hospitals to change and to start to care about cost and quality. And that was in one of your papers from the 1980s. But here we are. You saw that ever-increasing curve. When you started RWJ, you could have focused on, you said that the forces are too strong, can't go against it. So now you've been here with us for a couple of days, and we're not just focused on the cost, we're actually focused on improving quality as the key way to reduce cost. Are we going to look back 40 years from now, read the stuff that we're talking about and say, boy, isn't that cute? Those guys were all there trying so hard to solve this problem. And then we're going to be up at 30% the GDP spent on healthcare and quality just as poor as we have today.
That's a great question. I wish I had a good kind of crystal ball. I would say 2 things. One is we got from 10% to 18% because of politics. People who need and want medical care and people who the huge part of the economy that's providing medical care have a lot more clout than school teachers, social workers, poor people, the homeless. They vote more, they give more campaign contributions. And so when push comes to shove, healthcare always triumphs. And that's a political kind of an equation. What you're working on, which has some promise here, is you're trying to say, we're going to save the taxpayers money by doing upstream. We're going to prevent care. We're going to prevent the need to get in the hospital. We're going to do a preventive, we're going to find diabetes and colon cancer and all that. I think there's some problem. I think that tends to be oversold in the experience I've had. It's wonderful, it's good health, it's good value. You don't want someone to get colon cancer, but you got to do a lot of expensive colonoscopies, maybe a lot of not so expensive fecal alcohol blood tests. So that calculus, when I've looked at it, it's closer to the bone than I'm hearing here, but I might be wrong. Looking at frequent flyers, trying to find patterns where you can intervene, looking at patient compliance for medications, all those are good things. So they're virtuous. They have the promise of saving money. I think we're going to need more fundamental issues, though, like we talked about with the students today, changing the culture of how medicine is practiced. What I was saying is that sin, and my son Alan uses this, sins of omission trump sins of commission. So if someone comes in with a brain tumor and hasn't had a CT scan, shame on that doctor. If they come in for something else and had a brain scan and didn't work out, that's okay. If you get an angiogram for chest pain where you should have really felt that there was a rib fracture, and you get a complication from the angiogram, well, we did the best we could. If you don't do the angiogram and you get an MI, oh, shame on you, Dr. X, you did a bad job. And then how doctors get paid. The other thing I've noticed is the corporatization of medicine. So I sit on a hospital board. I've been actually on 2 hospital boards. And the CEOs, now they used to be called hospital directors. They're now called hospital CEOs. And they routinely make $1 to $5 million now. And although they may, in their heart, want to improve the health of the community, the things that they're measured for, that they get their bonuses for, are margin, expansion, keeping doctors happy, and hitting the metrics that the payers pay for. So I think it's going to require a sense of what we're forfeiting from not from spending so much on healthcare, particularly at a time when the tax base is frozen. I think it's going to be hard. I think it's a good rallying cry, but I would be diverse with your strategies, because I think this is a big turtle, and it's been there a long time, and it may be kind of cemented on. I'm sorry to rain a little bit on the parade, but
Well, I think
I hope I'm wrong.
I hope you're wrong too, and I guess it's our job to prove that. But certainly going to remain a rallying cry for us. And in changing, some of those fence posts that you talked about, like changing the way physicians are reimbursed and changing the way hospitals are reimbursed and we're reimbursed for care. If we don't do that, then I agree with you. We can't solve anything downstream.
I should tell an anecdote. The cost-retaining experiment that I said failed, the reason I got that funded, Jimmy Carter in the late 1970s did a major cost containment effort. And he was really pushing hard for it. And it wasn't obvious that he was going to be one-term president then. And so the American Hospital Association said, you don't need to do that, Mr. President. We're going to do the voluntary effort. Hospitals will voluntarily generate a whole bunch of programs at a lower cost. And I pitched to the foundation that funded us, it's not going to happen. And I didn't tell my staff who were working on the interventions, but when it was a negative study, I smiled a little bit, because that basically said that you're not going to get it voluntarily unless you have support like you have here. You may pull it off here because you've got support of the senior leadership.
Yeah, well, time will tell. But that's, okay, I guess we could take one real quick question and then...
Can the kind of change in controlling costs you're talking about ever come about in a capitalistic system? As soon as you talk about hospital CEOs making anywhere up to $5 million a year, you're into the same problems that they're in with executive compensation in companies across the board. And it feeds on itself. They serve on each other's boards. They bring in compensation consultants who want to get business from the other people on the boards. It'll never happen.
What's interesting, what they do is they tell the board, you probably want to compensate your CEO at the 75th percentile with incentive plans to get him or her, usually him, up to 90. And of course, if everybody's at 75th percentile, it just keeps going up.
Yeah, all right. On that note, so pleasure having you here. Thank you so much. It's really an honor. And Steve will be around for a little bit to answer some questions. So thank you.